So without further ado, we're going to get straight on with our first abstract by Andrew Hornby and colleagues. And this is on mapping variation in local amputation rates for 5 years. Thank you.
Good afternoon, everybody. Thank you for allowing me the possibility to present here today. In Northamptonshire, we have an adult diabetes population of 48,500, which is served by 71 GP practices. Following an annual performance review, it was highlighted that a rise in major amputation rates were present from 2014-15. And that can be seen in this graphic here, with figures dating back to 2012 all the way through to 2015-16, showing an upward trend in a previously stable picture. The aim was to review the major amputations geographically in order to identify variations in numbers and rates and target the areas of increase and the patient-facing services in these areas, namely GP services and also community nursing, and to work jointly to deliver improvements in care and ultimately reduce amputation rates. The raw amputation data was obtained using coding for major amputations consisting of at least one diagnosis code as per the slide and a procedure code as per the slide. This data was triangulated internally within the service between the specialist foot teams and also using other data provision sources such as trauma and orthopaedics, podiatric surgery and the National Vascular Registry. The triangulated data was then further organised via postcode and mapped into predetermined localities for the county. From this data, each locality was RAG rated, and this was applied with red, amber, yellow and green being allocated equal intervals, with a red rating highlighting statistics over the national average for England and Wales. GPs, practice and district nursing teams were then directly targeted for contact and instigation of multiple interventions. This was initiated by a county-wide PLT session for GPs. Intervention predominantly consisted of the provision of face-to-face education on diabetic foot disease, including how to make red flag acute referrals into our service. Education consisted of monthly scheduled sessions at localities across the county, with the additional choice of bespoke sessions for primary care and NHFT in order to provide maximum availability and assure maximum exposure so that the maximum number of clinicians could attend. These sessions continued during COVID, but on a virtual basis via MS Teams, and the clinical link podiatrist facilitator organised a hot foot line where advice to practice nurses and community nurses could be arranged. They arranged rapid access into our community foot clinics and gave advice and assistance on admitting patients via GP or via ambulance. From a community aspect, these sessions were also offered and delivered into other diabetes patient-facing clinical teams, which are listed on this slide. For delayed referrals into the service, namely those which did not meet the NICE and local guidelines for acute referrals, which is referral within 1 working day of presentation, a DATIX report was raised. And in these cases, practice managers and lead GP clinicians from primary care and service managers and team leads from community care were contacted to highlight the incident and to request an investigation and response to the delay. And in all instances, bespoke education sessions were offered following the delay to encourage engagement, especially from GPs. Engagement with education provision increased over the relevant period, as you can see from this graphic, particularly in the last 2 years of the period. And so the results. When the results were plotted using the RAG rating for major lower limb amputations by rates per thousand, for the baseline year of 2015, we showed multiple localities lying in the red category, indicating rates and numbers above the national average. This can then be compared to the rates per thousand for 2019-20, which following the RAG rating targeted interventions that we spoke about, show reductions in rates per thousand across all localities except one, and just a single area remaining within the RAG rating, giving an overall trend of reduced numbers, which can be seen in this graphic across the county for the period studied. As a result of these targeted interventions, we have also highlighted improvements in delayed referrals across the service, as you can see from the red ringed areas, with the total numbers of delayed referrals from allied health professionals having reduced year on year as per that slide. Training and education sessions have been made role-specific on the electronic staff record for NHFT community staff who are diabetes facing. And the local CCG now recommend diabetic foot disease knowledge refreshment every 2 years for all clinical staff in primary care. Our service has been chosen as a pilot site for a project to help GP registrars and new doctors into the NHS within Northamptonshire, how they can better understand the community services available, and that will involve a face-to-face clinical observation day. So in conclusion, the visualisation of the unwarranted variation found in diabetes amputations between localities focused the team's efforts to target resources and interventions, and from this there is scope for major amputations to be reduced with an improved delivery of care by targeting resources.
Thank you.
Okay, I'm going to be introducing Simon Asheville, who's going to talk on root cause analysis in the North East and its effects.
A clean lecture.
Thank you. So I'm presenting these data on behalf of the Northern Diabetes Foot Care Network who are involved in this work. The aim of this work is to perform a regional root cause analysis of major amputations across the North East, to look at factors contributing to amputation and to compare these data to a previous cycle in 2014, with the idea being to reduce major amputations across the North East. The work was coordinated by and performed by the Northern Diabetes Foot Care Network, who developed a data collection tool in 2014. We presented data from that region-wide audit at this conference in 2016. We then modified that tool in 2019 and collected data for all people admitted acutely for an amputation in the calendar year 2019. And as soon as possible following the amputation, there was an MDT case note review to look at the processes of care involved. In 2019, we had 6 sites in the North East involved compared to 5 in 2014. We looked at a similar number of amputations, which was 87 in total. There was a slight change in the level of amputations comparing 2019 to 14. In 2014, there was about 2/3 below knee and 1/3 above knee, and that became closer to 50-50 in 2019. The people having amputations were mostly male and mostly admitted on a non-elective basis. The site of the primary foot problem was predominantly digital, followed by heel and then forefoot ulceration. Unfortunately, the slide has taken away the graphics that were shown on here, so apologies for that. This is the key slide, looking which all the graphics have been removed from, looking at the processes of care that we examined comparing 2014 to 2019. 2014 is shown in the dark blue, 2019 is shown in the light blue. And I'll try to remember what those data shows, but there was approximately a 50% reduction in a number of people who were not seen by a member of the Diabetes Foot MDT within 24 hours of admission, comparing 2014 to 2019. There was also a 50% reduction in the number of people who were not given antibiotics appropriately based on their tissue cultures or based on microbiological advice or hospital guidelines, comparing 2014 and 2019. The number of people who didn't have their foot pulses recorded within 24 hours of admission was the same in both data cycles, in about 15%, and about 20% of the people in both cycles hadn't seen a member of the Diabetes Foot MDT service within 6 months prior to admission for amputation. There was about a 25% reduction in a number of people who did not have a foot X-ray performed within 24 hours of admission. About 13% of people didn't have an appropriate offloading device used in 2019. This data wasn't recorded in the first cycle, so we don't have data for that. Again, unfortunately, the graphics have all gone, but there was no major differences in revascularization procedures across the two periods. About 25% of people had a revascularization process performed. Well, this has worked. We asked the MDT whether the amputation was considered potentially preventable, and gladly there was a 50% reduction in the number of people in whom the amputation was considered to be preventable, comparing 2014 and 2019. And we then asked what were the factors associated with a potentially preventable amputation, and that was split 50-50 between deficiency is in the acute care of someone admitted with an acute diabetic foot problem, and 50% down to patient concordance issues. We looked then at factors that contributed to a non-avoidable major amputation, and the predominant cause here was non-reconstructible peripheral arterial disease, followed by sepsis, and then patient non-concordance listed again there. And we looked at the time interval from the foot problem developing to amputation in 2014. And again, we looked at this in 2019 and showed similar findings of marked variability. Some people having amputation very soon after presentation, some people a long time down the line. So in conclusion, performing a root cause analysis process has led to local benefits in terms of identifying deficiencies in care, and on a regional basis has shown some improvements in care between 2 audit cycles. I'd like to thank all the members of the Diabetes Foot, Northern Diabetes Foot Network who provided this data and worked on this together.
Okay, we now introduce our next presenter, Thomas Dickey, Head of Podiatry in Leeds. We're still staying in the northeast. And he's going to ask the question, how reliable is your National Diabetic Foot Care Audit data? Which will be R, I guess.
We hope. Thank you for inviting me to talk. I'd like to formally take this opportunity to thank my co-authors, Dr. Begonia Alsacia-Pitash and Helena Mealy, who helped me pull this together for today. This is really regards about coffee chats and saying, how good are we? Do we want to be better? And this is what we pulled out of the fact that we thought we were good, and then we realised we weren't that good. So how reliable is your and our diabetic foot audit data? It's really important because it's national and it drives change. However, we missed a point, we missed a trick, I think, in the fact that this is real-time data and it can be extracted from your region, and you don't have to wait for the published data, which is obviously a slight delay. So we wanted to look at our continuous data collection. We wanted to prove what we're doing and evidence change and evidence the fact that change means we need to improve. This audit, obviously, for those you don't know, I'm sure you do, is UK-wide. It looks at structures, processes and outcomes. In my opinion, this is for me, but it's taken from the author, Professor William Jeffcoat, in the fact that there's low ascertainment possibly, and therefore we should consider the findings with caution. Centres, when we did this audit, 2016-17, there was 180 centres that were supposed to be inputting data that ranged from 0 to 640. We were third in that table, and we thought, oh, it's a table, we need to do better. Humber was at the top at that point, so well done, Humber. But then we thought, well, why aren't we better? And we looked at that in more detail. So we considered looking at our own data in real time, which meant we needed to change. We need to use the Leeds improvement method, quality improvement methods. We needed to standardise the way we do things, because if we don't standardise, we get variation, and we leave all the data collection to the end. We don't batch, and that means we improve. So we've been inputting data in a monthly and quarterly aspect and doing assurance audits to make sure that we're doing that. And we did that by changing our job plans, making sure it's dedicated to be done, and we looked at analysing missing opportunities within that data set. So the most important part that this is, with regards to looking at missed opportunities, is when we looked at this from 17 and 18, we said, how good are we? We did the assurance at the end of the year when we tried to bulk load all the NDFA front sheets, and we found that we were missing 370. And once we put in place the assurances for that year, we did the audit again next year, and the missed opportunities came down to 33. So we only had 33 to find and upload. And what we did was we just extracted the data for NDFA for our region and cross-checked that against all our software that we have in our trust. So this is just an example, obviously, of real-time data. So we could pull this off tomorrow, and we'd get last week's data in there from that point of view, if it's uploaded the UK, which I believe it is, talking to our colleagues in Leeds. But this is looking at time to presentation, and this is the line that we're looking at here, which is when we did the audit, or we said, what should we do better, and this is how we should do it. Interestingly, the Foot Protection Service started in 2017 late, so it took a while to actually get going, 3 to 5 years before that we see the impact. However, we did see a change within that data set when we pulled it out from our own region. Yes, we've got better, because we're looking at this purple and blue line to say if they're in that zone, then they come out with worse outcomes. We don't know why there's a dip here where we've got a huge proportion of patients that are delayed treatment, because the Foot Protection Service was in place then. We don't really know from that point of view. So to conclude, really, this audit supports the fact that we can improve where necessary to increase ascertainment and reliability. And that will only improve, obviously, locally. But if we all did that, it would improve the UK version as well, and probably help William Jeffcoat perform better in regards to the advice that he gives us from that change. Possible strategies, yes, you can use tools, year-end audits, it doesn't really matter, just as long as you can assure that you've done the improvements. It's to encourage the fact that we're making decisions on pure evidence, and the evidence is the fact that we're collecting all the data. We're not using evidence-based decisions on snapshot data. And obviously, to review the national picture, we'll wait until there's a talk tomorrow about that from William Jeffcoat. Thank you very much.
Thank you.
On Adrian Hill to talk on behalf of a multi-centre study from Salford, Kings, the West Indies and Manchester, and he's going to report on determinants of death related to location of foot ulceration.
Thank you, Joe. You've already saved my time because you've done my first slide for me. So it's great to be presenting on behalf of co-authors from Salford, from Barbados, Mexico City, and Mike Edmonds from London. So we previously demonstrated in both a longitudinal study and in a systematic review meta-analysis that all-cause mortality is significantly higher, as we all know, in people with a history of diabetes, foot ulceration, compared with people who do not have any history of diabetes, foot ulcers. And importantly, and we presented this data here 5 years ago, in 2016, we found that the risk of death, independent of other factors, actually increased per quintile of social disadvantage. In other words, even if a person had a foot ulcer, if they were in a more disadvantaged social situation over a period of time, over a 10-year follow-up period, they were more likely to die in relation to having that foot ulcer if they're in a more disadvantaged situation in terms of their socioeconomic position. And the two papers that I'm referring to, the social deprivation one was published in Diabetologia a couple of years ago, and the meta-analysis systematic review in diabetic medicine last year. In the light of that, we were interested to determine in a single centre follow-up study in our group of people in Salford with a diabetes foot ulcer, what happens to them over time. So we recruited 98 individuals, just at the top bullet, consecutively in the Salford Royal Multidisciplinary Foot Clinic in 2016. 17 had type 1 diabetes mellitus of the 98, 81 had type 2. The mean age was 63.6, which with an age range of 28 up to 90. HbA1c not great. Mean HbA1c 72, 97%, very much in keeping with the Eurodial findings, had neuropathy. 62% had evidence of vascular insufficiency on the basis of Doppler studies. And what we were interested in this study is how the location of the foot ulcer, in other words, either forefoot or hindfoot, actually related to the likelihood of dying. In other words, was there a difference according to the location of the ulcer with regard to likelihood of dying? So of the ulcers, 60 9% of the ulcers were forefoot, 23% were hindfoot, and the rest were kind of lower ankle ulcers. So that's the other kind of percentage that's not actually quoted there. But 69% of ulcers were forefoot and 23% were hindfoot, in other words, heel in location. Of the people followed up, so they were all followed up to 4 years, 48 out of 98, so 2/5 of the people had died. Importantly, and this is one of the key messages, 27% of death certificates included sepsis and 35% renal failure as a cause of death, and the sepsis was not foot-related. And key message is that the multivariate regression analysis indicated a 6.3-fold increased risk of death for those people who had a heel, in other words, hindfoot ulcer, versus a forefoot ulcer. So a significantly increased risk of death over the follow-up period in those who had a hindfoot versus a forefoot ulcer. When we look at the Kaplan-Meier survival curve, we have the forefoot ulcers in blue, the hindfoot ulcers in red, and you can see that even just from about 5-6 months out, there's a separation in the lines so that the survival of the people with the hindfoot ulcer in red is less good, so more of them are dying over time than with the forefoot ulcer. So in this prospective study, to conclude, we have indicated that a higher term mortality rate long-term mortality rate is associated with a person having a hindfoot versus a forefoot ulcer. We've shown a close relation, as has been reported today as well in other talks, between sepsis, renal failure, and the likelihood of dying of the diabetes foot ulcer. So to conclude, the findings of our study suggest that in people with diabetes, please take a heel ulcer, hindfoot ulcer very seriously. There are various reasons why that we'll be happy to go through in questions, but also we need to bear in mind that causes of death in this group are cardiovascular and renal, and it's really important that, as always, we target those particular features of the individual, even perhaps in a more acute way than we do even for other people with a foot ulcer. So take-home message, hindfoot ulcers, very dangerous. Let's look after these people very closely, very carefully. Thank you.
We move on to the next one. Whilst you're sanitising the stand, I should have told you at the beginning, we only could accept 40% of the abstracts submitted this year. And normally would accept more, but apologies to those who didn't make it. There were some good abstracts, but because of the time restriction, we could only take the top 15 or so. So we move back east from Salford to Leeds again, and Thomas Dickey again. Minor amputation rates, diabetes limb salvage service.
It's been a while, thanks. Thank you again. I'd like to formally thank my helpers and co-authors of this, of David Russell and Dr. Heidi Silver from Leeds. We were looking at reducing minor amputation rates in the limb salvage service, and we wanted to use a guide because we were challenged by the commissioners. The background was that we had a rising incidence of minor amputations. Just seeing here, and obviously the CCG crudely said, oh, you're going to double in 6 months, so you're going to be way over. And we know that the Leeds rates was higher at that point as well. So we used and reused the Diabetic Foot Network root cause analysis tool for major amputations designed by Yorkshire and Humber's Diabetic Foot Network. Thank you very much. We did talk to them prior to this audit. It was a retrospective, quantitative and qualitative design because we were looking at the patient journey through the notes from that point of view. This is just a snapshot slide of the data that you got to input from the database. If everyone's used this database, you'll know that it's actually quite hefty and very, very time-consuming. We used coding from LTHT and then cross-checked that and used the software-based LTHT in Leeds. We had a date range, and it's not a nice 6 months one because we had 7 months, so we said, let's use all the data that we've got. So we used 7 months worth of data. After the exclusions of all the minor amputations, we ended up with 59 outcomes, so 63 minus 4, that is. When you map this across Leeds in the postcode area, we've got probably a higher proportion down on the east side, and maybe a spattering sort of south side as well. And if you look at the statistics for social deprivation, the highest in Leeds is in this sort of map here that I've just drawn from that point of view. So it sort of tallies the fact that it is targeting those in need. I'm going to skip over this slightly. This is not really much change from the last audit we did in 2014-15 or the national picture as much, but obviously this one was concerning and was highlighted to the diabetes team at the time from that point of view to try and encourage that we target this poor glycemic control. So, slight mistake, this is 7 months, not 6, it's my mistake. This is looking at the variables across the database and the numbers that we have that were known to the vascular service and 13 missed opportunities from a vascular issue. The most striking point was the fact that podiatry was not accessed, one with regards to community within, this is within the community podiatry and hospital based, and this is accessing podiatrists in the last year. So 50 out of the 59 did not have any podiatry input in the community prior to their minor amputation. There was a large number that missing from the MDT as well. And of that large number, we're going to come on to in a minute about the missing ones that went straight to amputation. Antibiotics were predominantly well used with regards to the pathways and the sampling that was taken. So this is just looking at the how they got to us within the NDFA work that we do, and this proportion here, nearly a quarter of all our or just over a quarter of all our patients went straight to amputation. So we didn't see them until they had an amputation. So there's a massive missed opportunity there. The reasons for the amputation, according to the database when we reviewed it, the majority was infection in that respect that caused the amputation to be done. And that would probably relate to the fact that they were late presenting as well, which is obviously a common theme that we do know about within this lecture theatre, and also the previous research has gone on. So when we have patients, previous amputations they've had, but they've also had a presenting amputation. The 15 we looked at a bit more closely. So we identified those 15 from the database. Unfortunately, 4 died post 7 months. 3 were not contactable. 3 amputations were now out of area. 1 was not able to answer due to mental health issues. That only left 4 patients. So they were called, talked to, realistically, just to get their version from that point of view. Strikingly, we obviously, we couldn't get a clear message from that because there was only 4 patients, unfortunately. We thought we'd had more. The striking issue was the fact that they had, they spoke 2 out of the 4 said nothing could have been done to prevent that minor amputation. This is just the themes that we've got out of that, the fact that we've got not seen and patient delays in there, which is high. So in conclusion, we could do a regression analysis, but we need larger data and a comparable one. There's no overriding causality, but infection was high for this group, and I think that's from a delay point of view. And of note, 27 of the cases we could have influenced, and we didn't influence of the 59. And we need to clean up some of the missing data in the database. It's about 5%. Thank you.
Our next speaker is Anjali Santakumar, who's going to talk on healing rates in the elderly patients with neuropathy, compared presumably with the younger group.
Good afternoon. Thank you to the Chairman for the opportunity today to present our study at Leeds on healing and clinical outcomes of neuropathic diabetic foot ulcers in the elderly. Now, elderly indeed are considered the fastest growing age group worldwide. Numbers over 80s are set to triple by 2050. Now, although the diabetes care guidelines now separate these elderly patients have individualized medical treatments, evidence on management of foot ulcers in the elderly remain limited. We also know that there can be structural and signal changes in the aging skin that can impair wound healing. Now, the aim of our study was to determine the healing outcomes of neuropathic diabetic foot ulcers that can be achieved in the elderly by routine care provided at an established MDT clinic and to explore age-related issues around the management of their diabetes and foot disease. This was an observational retrospective study of outcome of routine care. Patients with evidence of peripheral vascular disease or infection at presentation were excluded. A total of 97 patients who presented with a superficial neuropathic diabetic foot ulcer, and importantly, who were above the age of 65 at the time of their initial review with us, were identified using our electronic patient system, which amounted to a total of 107 ulcer episodes. Now, these ulcer episodes, we classify them into two further groups. Group E, or the elderly, which consisted of patients above 80 years, and Group Y, who were younger and aged 65 to 75 at the time of assessment. Now you can see we had a total of 45 in Group E and 52 in Group Y. There were more males in both groups, and all of these had type 2 diabetes except for 2 in the younger group, and in fact we noted that the elderly had a tighter control of their diabetes. We also identified a significant falls risk in the elderly, with nearly 11% of the elderly population having suffered a fall. 50% of these falls, unfortunately, were directly attributable to the offloading footwear we gave. 4 patients had died with the ulcer, and a total of 8 patients across the two groups were lost to follow-up and were excluded. You can see there were many more plantar ulcers in this group, and most of our ulcers had a Sinbad score of 2 or less. Sorry, this seems to, okay. So this is the healing rates that our elderly population managed to achieve. You can see just over 50% achieved healing at 12 weeks, with an impressive 80%, I think, at 24 weeks. Now, while we can't compare, obviously, these different studies, but it's useful to see where our Leeds elderly data fit in with both the less severe ulcer NDFA report and the insetile neuropathic ulcer data, both of the studies which had much younger population than us. And you can see similar healing rates. The fourth is a Swedish study that did have similarly aged population as ours, but they included ischemic ulcers, and their data suggested primary healing in 54%, with a slightly prolonged healing time to healing. Now, it was apparent early on when we examined these electronic patient records that there was significant reduction in mobility of our elderly patients. So to try and explore this a bit better, we looked at individual healing rates of dorsal versus plantar ulcers. Now you can see here, the plantar ulcers here are depicted in blue. And in the elderly, they showed just under 50% healing at 12 weeks. But at 24 weeks, a large significant proportion of these ulcers healed. This is the same data in the younger population. You can see that the deep blue ulcers, again here of the plantar ulcers, they seem to sort of lag behind their elderly counterparts, achieving just around 60% healing at 24 weeks. So putting this together, I've gone for a bit of random choice of colors here, but the bottom 2 lines here show the plantar ulcer healing, the orange being the elderly and the black being the younger population. You can see they have comparable proportion of healing at 24 weeks, and then they significantly sort of diverge, and the elderly plantar ulcers appear to be healing in larger numbers. So there are obvious limitations to our study, small numbers. We have not done any formal mobility assessments at all. However, I think we can conclude that despite age-related skin changes, the elderly are capable of really healing their neuropathic foot ulcers. Given a bit of time, they in fact seem to be doing a bit better than their younger counterparts. Plantar ulcers appear to heal quicker than the dorsal ulcers in the elderly. A potential explanation might be a layer of protection offered by their reduced mobility. Falls remains a significant risk in the elderly population. Thus, perhaps a shift in focus or perspective from offloading footwear to maybe falls assessment and mobility assessments might be a better guide and measure of patient care and outcome in this group. Thank you.
Thank you.
So now we move west again from Leeds to Blackburn, and Jill Lomax from East Lancs Hospital Trust, instigating inpatient podiatry provision for diabetic foot team at the weekend, a very important topic.
Okay. Good afternoon, Mr. Chairman, ladies and gentlemen. This presentation looks at some of the outcomes of podiatry provision when weekend working was commenced at East Lancs Hospitals Trust. It's loosely written on the KISS principle recommended to my esteemed colleague and friend, and it means keep it simple, stupid. So the first very simple slide shows staffing in the acute diabetic foot team up to September 2017. We had 4 podiatrists, 1 foot care assistant, 8 o'clock till 6:30 Monday to Friday working, and of course our consultants were working the 7-day pattern as in all trusts. In 2016, NHS England invited NHS trusts to bid for monies to support improvement in the treatment and care of people with diabetes. 2 targeted areas were the reduction of amputations by improving access to multidisciplinary foot teams and reducing lengths of hospital stays by improving access to specialist inpatient support. ELHT was successful, and the funding had to include the proviso to commence weekend working, a true 7-day podiatry service. Following NHS England's transformation monies, we acquired 5 new members of staff to make a total of 9 podiatrists, and we implemented weekend and bank holiday working. The primary functions of 7-day working were to improve access to the diabetic foot team to assist in reducing the number of amputations, to see diabetic foot patients in a more timely manner, to create effective, planned and appropriate discharge, to help prevent admissions at source, and to try and educate staff and patients through increased exposure to the diabetic foot team. So how and when did all this happen? The diabetic foot team saw inpatients throughout East Lancs hospitals, of which there are 4. We saw emergency department patients at source, and we accepted patients and staff consultations via our Hot Footline mobile telephone. The costs of weekend working are shown in this slide. The table shows the 5-hour shift cost for each podiatric band. On average, 7 podiatrists, band 6, 7 and 8As, would work 8 weekends a year with an estimated cost of over £25,000 per year. Looking at the new and follow-up patients over the 74-week sample, a total of 385 new patients were seen, 360 on the wards, 7 in ED and 18 via the Hot Foot line. Follow-up episodes defined as a patient already under the care of the hospital diabetic foot team accounted for 183. Reasons why new patients were referred was many. Out of 361 inpatients, 116 in blue were appropriately escalated to the diabetic foot team at weekend. 131 in red were inappropriate referrals for the diabetic weekend working priority. Some of the reasons are listed at the bottom of the slide. A further 71 patients in orange have been referred for simple nail cutting. 17 patients in green had no foot problems at all, and 26 did not even have diabetes. Both ED and telephone consultations, though, were 100% appropriate. Similarly, 121 follow-up patients out of 177 did not really require that diabetic foot team weekend input, and they could have waited until Monday morning weekend working with no adverse effect. 56 inpatients and both ED follow-up patients benefited from diabetic foot weekend working. So, 67% of patient referrals during the weekend working sample did not need escalating to the weekend service, costing approximately £21,000 in clinical staff time. So did discharges improve? Well, yes, but marginally. 3% of new referrals, 9% of follow-ups had effective discharge, helped by the diabetic foot team weekend working. But however, if you look at just one discharge for one night, estimated at around £350 per hospital bed is achieved, there really are considerable cost savings for advocating the diabetic foot team weekend working. So, thoughts. 33% of patients were referred appropriately and benefited from the diabetic foot team care at weekend, and hopefully this did translate into reduced bed days and better outcomes. The highest proportion of inappropriate referrals in both new and follow-up came from patients who did not need their care escalating to the weekend service. One of the functions of weekend working was to support increased discharge of patients, and in both new and follow-up contacts, the diabetic foot would achieve less than 10%. However, it does equate to considerable cost savings. Although numbers were small, both ED referrals and telephone consultations were appropriate. All staff disciplines really need to partake in a 7-day service. Isolated groups doesn't really work. Overall, the quality of care really was excellent, and it was a truly patient-focused service. Thank you, and it's coming home.
Our next speaker is Dr. Fez Bajwa, who's going to talk on a very similar sort of topic, and that's the benefits of a diabetes specialist nurse to the multidisciplinary foot team. So again, service improvement and its outcome.
Okay, so many thanks for allowing me the opportunity to present my audit. We did this audit last year, sort of between the first and second waves of COVID. I'm Fez Bajwa, I work at the Queen Elizabeth Hospital. I'd like to acknowledge my co-authors, Mr. Tiwari, vascular surgeon, and Dr. Said, diabetes consultant, and also shout out our diabetes specialist nurses, Deborah Dawson and Michelle McMahon, who were interested in diabetes foot care and took part in this audit. So in terms of a background, we've had an MDT service at Queen Elizabeth Hospital for over 10 years. The MDT structure consists of 2 diabetes consultants, 1 vascular consultant, and 4 senior podiatrists. As you can see, we have access to microbiology consultants. Although they're not there face-to-face, they were there previously. We have a system that works quite well, and also the orthotics department is just next door, and we have a close working relationship. As you can see, we don't have, or traditionally have not had access to diabetes specialist nurses within the team. In fact, the clinic is at one end of the hospital in podiatry, and the diabetes center is at the complete opposite end of the hospital. So it was unrealistic to have patients with poor mobility, foot ulcers, foot problems to go to the diabetes center to see a DSN. The service runs, we have a clinic, a 4-hour clinic once a week on a Wednesday morning, and we do 2 with a plan to initiate a second clinic soon. And twice weekly we have an MDT ward rounds. And the aim is quite simple, to assess the value of embedding a DSN within the MDT structure of the clinic. Patients were prospectively audited over 12 weeks, with the primary outcomes looking at HbA1c change and ulcer outcomes. This is not working. No. So in terms of results, we audited 61 patients, and these demographics shouldn't surprise anybody in this room. So the majority of patients were of male, gender, long duration of diabetes, mainly type 2 diabetes, not a brilliant baseline HbA1c, 76 millimoles per mole, a large percentage on insulin, a lot had previous amputations, majority of which were minor amputations. And again, unsurprisingly, 64% of patients had forefoot ulcers. Up to half of our patients had either clinical or radiological evidence of osteomyelitis and treated as such. And the baseline SINBAD score was 3. In terms of DSN intervention, we had a brilliant talk yesterday from Rachel, I think, from Leicester, about a very hybrid and evolved DSN role. Our DSNs took a very basic approach to the patients. They really went back to the core principles of education and diabetes understanding and management. Because what we found in our clinic was patients really didn't make that link that it's because of the underlying problem of their poor glycemic control that they're in the clinic with a foot problem. So this list is by no means exhaustive. Patients were seen at least once face-to-face in the clinic and contacted at least once remotely to review and reinforce the advice given in clinic. And as you can see from this slide, a large proportion of DSN time and resources went into education, particularly hypoglycemia education, and also to facilitate blood glucose monitoring, either providing a new monitor. We got a few patients on Freestyle Libre as well. So in terms of outcomes, at 12 weeks, we saw a 11 millimoles per mole or 1% in all money drop in HbA1c or improvement in HbA1c. And also the SINBAD score when assessed at 12 weeks dropped by 1 point. I know this is a multifactorial outcome, so we can't really attribute this just to DSN input, but this was what was observed in the study. So in conclusion, the involvement of DSNs within the diabetes MDT, foot MDT clinic has led to an improvement in glycemic index by 1% and an improvement, a reduction in the SINBAD score by 1 point, and above all, improvement in patient safety, particularly in terms of blood glucose monitoring and hypoglycemia. So future work is needed to evaluate the cost effectiveness of DSNs as part of the MDT. We're actually using this audit to put forward a business case to have ongoing support from DSNs in our clinic. Thank you. Any questions?
Thank you very much. And now we move back up to Tyneside, and Lydia Gristi and colleagues from Newcastle upon Tyne. 3-year survival rate after transmetatarsal amputations in high-risk patients with diabetes. Is it any better than major amputations?
Hello, good afternoon, everyone. I'm Lydia. I'm one of the endocrinology trainees at the RVI in Newcastle. Thank you for this opportunity to present. Today, I'd like to present an audit we carried out with the podiatry team. And I also need to thank Louise Darwich, a medical student who gathered the data. So it's an audit where we looked at the 3-year survival rate of diabetic patients who underwent transmetatarsal amputations, and we also had the opportunity to compare our results with major amputations that were performed in our same regional center. We looked at the years 2013 to 2018, and it was a retrospective data search of patients coded for the following. We made sure all patients were diabetics, and we excluded all patients who had just single-digit amputations. We collected data for date of surgery, surgical procedure, time to healing, progression to major limb amputation, and survival, amongst others. We ended up with a patient cohort of 46 patients. The mean age was 70 years. Most patients were male, and most had type 2 diabetes. The major indications for amputations were a non-healing ulcer and ischemia. We found that 33 out of our 46 patients underwent revascularization procedures within 12 months of their amputation. We looked at the surgical procedure itself, and we found that only 4 of our patients had a primary closure. The rest were left to heal by secondary intention with or without VAC dressing. We found that 20 out of our 46 patients healed within 3 years, and the quickest healing was in less than 12 weeks, and it included only those patients who had primary closure. 13 of our patients progressed to major amputations. We looked at the survival rates at 1, 2, and 3 years, and these were 74%, 56%, and 41% respectively. Our mean time to death was 21 months. However, we had quite a wide range between 1 and 71 months. More specific outcomes, so those patients who healed, 8 still died at less than 3 years. Those patients who did not heal, 22, so 85%, died at less than 5 years. The mean months from surgery for this was similar in both groups at 21 months and 19 months respectively. So as I said, we could compare our data with major amputations happening in our same regional center, and we saw that the percentages were actually quite similar to each other. In fact, we compared the 2 groups with a chi-square test, and indeed there was no statistically significant difference between forefoot amputations and major amputations in our center. So in conclusion, our healing and 3-year survival rates in patients with diabetes who underwent forefoot amputations was less than 50%. There was no statistical significance between those undergoing forefoot and major amputations in survival rates. So our audit raised some questions which we would like to look into further. We want to know how many of these people actually mobilized after forefoot amputations versus major amputations. We want to know why our healing outcomes are so low and should we be considering more primary closures. And definitely there's a role for MDT discussion and patient counseling. Thank you.
Our next speaker is Keely Jones, and this again is a staff intervention, in this case a pharmacist. So welcome.
Thank you. Good afternoon, everyone. So I'm Keely and I'm a pharmacist working at the Leeds Teaching Hospitals. Thank you for having me today. So we know that aggressive management of cardiovascular risk in patients with diabetes improves outcomes. We also know that intentional, non-intentional non-adherence is a major factor for treatment failure in these patients. There's evidence out there to show that pharmacists can help with both of these issues, with cardiovascular management as well as adherence. So back in early 2020, pre-pandemic, we proposed that having pharmacists present in the diabetic foot clinic at Leeds could help with identifying as well as resolving issues with medicines in patients with diabetes and hopefully improving care and outcomes for these patients. So to try and see where improvements could be made, we undertook a baseline audit of 50 patients who had attended clinic in the last month. And we found that 62% of HbA1c, 32% of blood pressure readings and 56% of lipids had scope to be optimised. We've re-audited this since and we found that the numbers were quite very similar. So in order to pilot the work of pharmacists in the clinic and in order for it to be a robust pilot, we sought funding from Novo Nordisk for this. So we have been in clinic now since May and we attend the clinic on each morning, so 4 mornings a week. And the new patients are reviewed prior to clinic by a pharmacist. Any action required within the clinic, so anything that needs to be done physically to the patient, bloods and blood pressure checks, is done in the clinic. And then a plan is communicated on the electronic patient record systems that we use up in Leeds. If there's any further intervention or advice needed from members of the MDT, we discuss that again in clinic with consultants and specialist diabetes nurses. And if needed, if a follow-up is needed or any further action from the GP, we write to the GP. So in May, 42 patients were reviewed prior to clinic, and these are the parameters we look at. So you can see that most of these make up the 9 care processes for patients with diabetes. We obviously, as pharmacists, don't look at the feet because we've got working alongside the specialist, so we don't need to be doing that. And then eye care is also missing. What we add to these parameters within the clinic is adherence of our discussion with patients. So this graph shows you the interventions that we made in the first month of being in clinics. So out of 42 patients, 9 patients unfortunately did not attend clinic, but if there was any actions needed from either being in clinic or in the future, that was communicated with the GP. You can see there's a lot of HbA1c and lipids requested, so prompts for those to be done, as well as requests for reviews by other members of the MDT. Referral to lipid clinic. So we have a pharmacist-led lipid clinic at Leeds Teaching Hospitals where patients can be considered for PCSK9 inhibitor therapy. And this is for patients who are either intolerant of statins or not meeting targets on optimal therapy. Discussions around adherence have happened, and then smoking cessation discussion as well, which is really important for our patients. So ad hoc interventions. So these are the things that we couldn't plan for before clinic, and these are the things that we've got involved with from having a physical presence within the clinic. So we've been able to advise on things such as drug interactions. We've liaised with community pharmacies to confirm what kind of medicines patients are taking and how often they collect their medicines. We've been able to advise on antibiotics, including appropriate dosing regimes and potential side effects for the patients. We've conducted full medication reviews and provided patients with aids for adherence to help with taking their medicines. Advice on statin intolerances, so suggestions of other therapies and then review antiplatelets as well. So especially important in our vascular cohort of patients. And we've also been there to advise on dose adjustments, especially with regards to renal impairment and antibiotics again. So next steps. So obviously we're going to be looking at the outcome of these patients, see if we've had an effect on the 3 treatment targets. You might notice that there's not much focus on blood pressure in the data we've collected so far, so that is something that we aim on doing in the future, to make sure that every patient gets their blood pressure checked on their first presentation to the clinic. And then there's discussions about a referral pathway for primary care pharmacy review as well, so either for follow-up or for structured medication reviews for patients that we might not have the opportunity or time to see ourselves in secondary care clinic before they're discharged. Thank you very much.
Thank you. Okay, we'll move on, and thank you very much. The next speaker is Ryan Rosecroft, and Ryan's going to talk on artificial intelligence for tracking wound healing.
Pleased to present today on a preliminary report of an ongoing study, thanks to the co-authors and for Mr. Najafi sneaking this in yesterday during his final talk. So we're looking at the use of artificial intelligence-based methods to track wound healing. I think we can all agree that it's important to track wound healing, especially in the context of the management of diabetic foot ulcers, and especially so in response to treatment. And it's often these findings that help to direct our treatments in either supporting or challenging their management plan. There are many ways in which we can track wound healing, such as through manual techniques and commercially available digital systems, but there does remain a lack of an accurate and reliable method. The most commonly used method in the UK and the USA to track wound healing is planimetry. But there's a fundamental shortfall with this technique, which is its inability to produce repeatable results between clinicians. And this is particularly important for diabetic foot ulcers because they're often assessed in multidisciplinary teams by a variety of clinicians. So I think it's important we address this shortfall. Leads me to ask you a question. Is it time that we replace the measuring tape with artificial intelligence? Planimetry itself is relatively easy to perform, but it means that the patient has to come to clinic. So whilst we don't need any expensive equipment, it's the facilitation of planimetry that's costly to healthcare services. This next slide is a summary diagram of the development of our model, and I'm pleased to report that we've completed the first 2 to 3 stages, with stages 4 and 5 still in development. Stage 1 has been the image collection, stage 2 has been the image storage onto our database, and stage 3 has been the image analysis, which I'll touch on in the next few slides. Stage 4 will be the development of a wound healing index, and stage 5 will be the reporting of our results. We've enrolled 28 patients into the study to date, and we're continuing to collect, who are predominantly male with type 2 diabetes and a mean age of 63 years. The most commonly presenting foot wound had a University of Texas classification grade 1A. Some of the wounds are ischemic and some of the wounds are infected. We've enrolled those patients with diabetic peripheral neuropathy, those with plantar diabetic foot ulcers, and those with at least 2 serial image captures of the same wound. And we've excluded the patients with surgical wounds. We collected the data on the patients who attended the Foot Hospital in Manchester, and we took their baseline demographic, social and medical information. The imaging was primarily undertaken by the medical illustration team, but in their absence it was conducted by the podiatrists, and we've used a range of imaging methods such as cameras, tablets and smartphones. The frequency of the images has been based upon the patient's follow-up plan as determined by the treating clinician. There's 2 images on screen which are a visual aid of the image technique. Your first image on the left is a full plantar surface view of the foot with the index ulcer on show, and the second image on the right is a close-up image snapshot of the same ulcer, but for full appreciation. You'll notice that there's no obstruction in terms of tape or identifiable information, and this is important for the AI. This next slide will highlight the various stages of the project with a bit of animation, which we'll go through now, more on image analysis. You begin with the baseline image, which is stored, and these images undergo wound localization, segmentation, and we start to pick out the main characteristics that we want to assess. We continue to take further follow-up images, and we align the follow-up image with the baseline image, and it's this aligned image that undergoes change analysis, and it's from this change analysis that we start to pick out the main wound change characteristics, and it's this information that we believe will influence the wound healing index. And of course, from this wound healing index, we get a better idea of the prognosis of the wound healing. So to finalise, our next steps are to enhance the wound healing index. We want to increase the number of wound descriptors and the clinical characteristics. And with further testing, we want to validate the wound healing index. We want to design an app with a great interface, good usability for both patients and clinicians, which houses a telemedicine service. And finally, to ensure good cybersecurity and security of data storage and data sharing. Thanks.
We move on now to Ipswich. Still in the east, but going south. And Dr. Sanjani Bade is going to tell us about diabetic foot care during the COVID-19 pandemic, a review of services.
Good afternoon, ladies and gentlemen. On behalf of my co-workers, thank you for this opportunity to present our data. The COVID-19 pandemic has had a devastating impact on diabetes. National diabetic foot audit outcomes are still awaited, but there's been information regarding reduced hospital admissions and poor outcomes in parts of the world. East Suffolk comprises of large, sparse rural areas with average patient age about 70 years. Like many of you, we had patients hesitating in attending hospital clinics and decreased accessibility to care homes. Very importantly, community foot services have been running in a marginalized manner due to less space and staff shielding. In the hospital, our MDT clinics comprising of diabetic consultants, podiatry colleagues, and vascular consultants were also reduced due to social distancing, less space, and our consultants running COVID wards and vascular support was ad hoc, and they were staff shortages. Despite that, we took quite a few measures to mitigate this risk. In place of meetings, we had email updates and we liaised with community services so we could transfer we could triage our patients and our referrals coming from primary care, and we transferred some of our medium risk patients to community services. We were aggressively promoting triaging our referrals, and costing services had to be reviewed again, so we bring patients back in 2 weeks rather than 1 week. We had to prioritize inpatient activity due to reduce length of stay. Finally, I'm sure you all agree, we were fortunate to have a diabetic specialist nurse in our foot clinic who managed patients with diabetes without additional diabetic clinic appointments in primary and secondary care. In the next few slides, I'm going to show you the retrospective data we collected in pre-COVID and COVID era between April 2019 and March 20, and then COVID struck us between April 2020 to March this year. We looked at our diabetic service provisions, diabetic foot outcomes, and general diabetes key performance indicators. First, let's have a look at outpatient diabetic foot services. You'll see that there was a reduction in both outpatient referrals and in individual outpatients seen, but our outpatient activity was not reduced despite the reduction in referrals. This is because we were looking into patients that were high risk. Moving on to inpatient diabetic service, yes, there was a reduction in overall inpatients due to COVID pandemic, but as you know, COVID-19 has significant outcomes in diabetic foot patients who might or might not have foot lesions. If we look at diabetic foot outcomes, we had quite a number of major and minor amputations, which was statistically much less than pre-COVID era. This vascular intervention data is only from Ipswich Hospital and does not include Colchester Hospital because we couldn't get the data in time for this presentation. We were very aggressive in performing angioplasties in our patients during COVID to promote limb salvage, and bypasses were greater in number with an equal number of endarterectomies. We looked at 3 particular key performance indices, and first one being HbA1c. Although it went up significantly, it was still within acceptable limits. There was no change in UACR and cholesterol data. I would love to show you more, but because of the time constraints, I will limit this to these outcomes. Now, looking at mortality, this data reflects patients with coexisting diabetic foot disease, but not necessarily it's due to diabetic foot disease. As you know, due to COVID-19, there's been increase in death rates. So this is the total number of deaths in patients who also had diabetic foot disease, not because of diabetic foot disease. We couldn't get the specific data to separate those two for now. To conclude, ladies and gentlemen, our main aim was to reduce hospital admissions, save lives, diabetic foot disease or otherwise, and salvage limbs. We wanted to support patients remotely and did a lot of telephone clinics. We liaised with key stakeholders. As for our data, it does not look as adverse as it might have been in some other places. I think we've done well. I'm sure you'll agree with some of these. I think in the future, given the COVID-19 and how much it's changed our organization and treatment that we provide, it's very important to reorganize MDFT if there is a third wave. Triaging is a part of our clinics now. Both video and telephone clinics are important. Community diabetic foot services have been decimated in many areas, and it's important to look into this to establish traffic lighting. Interdisciplinary communication with the vascular team and interventional radiology is also very important. Finally, patient education and prevention is the key. Special thanks to podiatry and diabetic foot teams in Ipswich Hospital, and particular thanks to Dr. Sharma for all his help. Thank you.
We'll move on now. Our next speaker is Alison Musgrove, who's going to talk on the relationship between HbA1c and QTc and mortality.
Thank you and good afternoon, everybody. We know that a prolonged QTc interval is an independent predictor of cardiovascular mortality and diabetes. And there's also evidence that occult hypoglycemia may cause delayed cardiac repolarization as reflected in a prolonged QTc interval on a routine ECG. We were struck by the results of this 2013 retrospective study from Sweden, which showed significant association between low HbA1c, QTc prolongation, and mortality in people with diabetes and foot ulceration. They reported a significant association between a baseline HbA1c of below 58 millimoles per mole and death, as well as between a QTc interval of over 440 milliseconds and death. They also found that a combination of these factors led to an almost double mortality rate than that of all other individuals in the study. The survival curve indicated that mortality differences associated with low HbA1c were clearly established from 12 months onwards. And for the combination of low HbA1c and prolonged QTc, association was seen after 24 months. We made a decision to carry out a prospective study in our centre in Nottingham, looking at the relationship between these two factors and following newly referred foot ulceration for 4 years for all-cause mortality. Now, we've previously presented our 2-year data at Diabetes UK, and although our abstract for this conference provided information only on that data, the postponement, or thanks to the postponement of this meeting, means we can now show you the 4-year follow-up. Our initial 2-year data suggested no association between low HbA1c, QTc prolongation, and mortality rates. However, our very recent results from 4-year follow-up has revealed a significant association with mortality rates in those with low HbA1c and QTc prolongation combined. It's difficult to draw exact comparisons with ours and the original Swedish study. Both studies were small, but mean age and rates of low HbA1c were very similar. However, theirs, as I've said, was a retrospective study, and their rates of QTc were far higher than ours. They were 35% compared to our 16%. What we were also unable to confirm their findings of low HbA1c and prolonged QTc being associated. It's relevant, we feel, that the cardiologist, the consultant cardiologist who actually reviewed all the study ECGs, recommended that unrelated to the QTc interval, 20% of our population should have their GP notified of cardiac abnormalities if they weren't already recognised. To sum up, we'd say that these findings do need confirmation. As I've said, it was a very small population we looked at, and we do look forward to seeing the results of a much larger multi-centre study being undertaken by Professor Jonathan Valabji and his colleagues in the UK. And that study's ongoing. But if confirmed, these results might suggest ways that greater attention could be paid to minimising cardiac risk in this population in the future. And just to add that I was really interested, Kelly, in listening to you, because I think that, you know, QTc prolongation and drug interaction, it will be, you know, an important part. Perhaps the pharmacist could also play in this. And thank you very much.
Last but not least, we go back to Manchester and Buxton, and Bianca Price and colleagues from the Division of Pharmacy at the University of Manchester are going to report on the efficacy of topical release compared to simulated systematic antibiotics in reducing polymicrobial biofilms.
Yes, it's a catchy title.
It is. That's not all.
Okay, thanks for giving me the opportunity to speak today. So I was working for 10 years at Manchester as a postdoc and then as a research fellow, and I'm now an honorary lecturer at Manchester. So this is a slightly different talk to the ones that you've had before. I'm going to talk a little bit about some lab data mixed in with some clinical data. So in our study, we wanted to compare the impact of topical antibiotics and systemic antibiotics on polymicrobial biofilms that were related to those that you might find in the clinic. So we completed an ethics and we recruited subjects to collect debrided tissue from. We collected tissue upon presentation with an ulcer, so prior to any treatment, and then after a week of their normal treatment. From the tissue that we collected, we harvested bacteria and identified them. From the 7-day follow-up, we also collected blood, and we assayed antibiotic concentrations in the debrided tissue and the blood after a week of treatment. And then from the initial presentation, we took the bacteria that we collected, put it into wound models, and then developed biofilms over 3 days. Then we added either topical vancomycin and gentamicin loaded into stimulant beads, which you can see in the picture on the left, or we added systemic antibiotics at the concentration we found in blood, and we added that to the media of the models. So this is some data about the patients. Half of them were treated with Fluclox. Then we had 3 different combinations of antibiotics, coamoxiclav, cotrimoxazole, and cipro and clindamycin. Not surprisingly, in the tissue, we didn't find very much antibiotics, a little bit of Fluclox in 2 of the subjects, but everything else was below the limit of detection or undetectable to us. But not surprisingly, we found more antibiotics in the serum. And so going forward in our modelling, we used either the serum concentration that we found, or we used the published Cmax values as our simulated systemic antibiotic concentration. So this is a heat map to show the changes in the bacteria that we found for each subject. So each of these boxes corresponds to each of 6 subjects. And what we can see is the red is high concentrations of bacteria and the blue is lower concentrations. So I wonder if I can get my pointer to work. There we go. Maybe not. There we go. Okay, so these first 2 columns are bacteria that we found at day 0, and the second 2 columns are from day 7. So we had a lot of the usual suspects, lots of stuff in our models, as well as Corynebacterium and the odd Pseudomonas. And what we found was that you could see changes in the bacteria present. So you might lose some, but then gain some. This subject was interesting because we found yeast in the wound, but we didn't find the yeast at day 7. And of course, the antibiotics wouldn't have impacted that, so we wonder whether that was lost during the debridement process. Okay, so just to reiterate, so we prepared these in vitro wound models containing fibroblasts and collagen, then we added the bacteria corresponding to the microbes identified for each subject. We added antibiotics to the media to simulate systemic antibiotics, or we added topical vancomycin and gentamicin to our models. So this is what the model looks like. We either put the antibiotics in the top here in the beads or in the media, and these are the fibroblasts, so if they're stained green, that means that they're alive. And you can see that the matrix that we've developed in the collagen is relatively similar to something that you might see in tissue. So we were interested in making sure that the substrate for the biofilm was similar to what you might find in vivo. So these are the results from our in vitro models. So each of these graphs corresponds to a different subject. We did not see a difference when we did simulated systemic antibiotics compared to the control in any of our subjects, even when the simulated systemic antibiotics was above the MIC. And that's likely because we were in a polymicrobial biofilm, so they're very robust and hard to kill. We did see big differences when we added the antibiotics loaded into beads, and that's mostly because we added an awful lot of antibiotics. Those beads carry a lot of antibiotics, so you'd expect to see a bigger difference. So this summarizes what we saw in the lab with our simulated antibiotics and the loaded beads, and this is what we saw in vivo. So we did see in vivo a 1 log difference in the bacteria across all of the wounds, and that was a significant difference. We didn't see that in the simulated models, we think because our biofilms were quite robust. So in summary, the microbial balance in diabetic foot infections is altered, we think, by systemic antibiotics, but of course we don't have a no antibiotics control in this study. A similar biofilm in terms of bioburden and microbial composition can be simulated in vitro, and our modelling showed greater log reductions in biofilm with topical release of antibiotics at really high concentrations compared to simulated systemic antibiotics in 5 of our 6 subjects. The final subject, of course, had yeast, and so we wouldn't have expected to see any difference there. And then I just wanted to acknowledge the people that contributed to the work. So Grace and Nat used to work in my lab. Robert is from Buxton, and Mark and Alan, we shipped them samples for antibiotic testing. And then thanks to Biocomposites and Perfectus for allowing me to be here.
Thank you very much.